Welcome to the last session of the symposium, where I will be reflecting upon the economic impact and return on investment of clinical academic roles outside of medicine. My name is Castro Sanchez, and I'm a lecturer at City University London. Obviously, the views presented in this talk are mine and not of my employers or any of the organizations I'm affiliated with. To give you some context, I think it's fair to say that there is uncertainty about the definition of the role and the expectations of clinical academics, particularly non-medical clinical academics, and the funding has often been blamed as one of the main reasons why there are not enough or no more clinical academic positions. It's also important to remember that metrics related to impact, as colleagues have already presented, are yet to be agreed upon, and there is a variety of impact frameworks. Some of these impact frameworks include an economic perspective. So, for example, the Victor framework and the modified Victor framework presented by Dr. Newton include economic sensitive indicators, but I will argue that these indicators are typically output driven. So rather than impact, they're really reflecting upon production output, and it may be also possible to think about the perspective of these frameworks and this economic perspective as typically managerialist, where we're really interested in measuring the production of the worker. For such reasons, the economic evaluation of clinical academics is challenging and can be challenging, and the classic economic evaluations require that a well-defined unit of output is measured against a well-defined unit of cost. But at the moment, as we said before, we're not quite sure what a clinical academic is or may be, and also we're still defining the units of output for clinical academics. So to these dilemmas, we can add some of the challenges to the existing metrics, which may be shortchanging the contribution, the wider contribution of clinical academics to the field. Often, research within the clinical academic role is seen as an opportunity cost of clinical work. So, in other words, when research has taken place, it's valued as clinical work which has not taken place. And in this particular experience, they calculated the cost of increasing research time for existing clinicians, medical consultants in this occasion. So the cost of increasing 20% of dedicated research time to 20% of medical consultants was calculated by reducing the amount of clinical time by 20%. So the cost to a district general hospital or a teaching hospital varied between 1.3 to 3 million pounds per year. So there may be also some additional direct costs attached to this experience, but in essence, calculations about increased research started from the point of calculating the clinical work, which was not carried out by the clinical academics. Economic impact has frequently been presented as income from clinical academics or savings generated by clinical academics. Thinking about income, traditionally, income refers to competitive funding obtained, and in these couple of examples, you have got how 87% of NIH in the US funded surgeons had dedicated research time versus 71% of them without funding. So increasing research time led to increased success in competitive funding applications, which therefore was an income generated for the hosting organization. And this income from different streams can amount to an important figure, and it's calculated at just under £200 million per year for NHS trusts in England came from revenue from life science company investments. So you have got here a couple of good examples of that income. Income as well could be a byproduct of what I call the research craft. So not just success in grant applications by the researchers, but increasing research time and enabling clinical academics to research, increase the number of scientific presentations in a particular program, or increase number of publications and collaborations, which then were much more likely to lead to successful grant applications, as we've seen before. So increasing research time seems to be associated with individual success, but also collective successes. That refers to income generation, but also clinical academics economic impact can lead to savings, particularly savings as a result of changes in how care is delivered. You've got a fantastic example here where a clinical academic introduced an innovation, the use of a portable bladder ultrasound scan instead of bladder catheterization, which led to direct savings to the NHS Trust hosting this academic by more than £1.2 million a year. And there could be additional savings related to fewer infections, treatment delays, and overnight hospital stays. So savings by not engaging in suboptimal care, essentially. There could be other savings related to fewer organizational costs, and in this case, increased retention. So increasing the research time for clinicians help, in this case, retain doctors in practice, was associated with increased satisfaction and career progression, and making essentially clinical practice much more attractive. So reducing the number of clinicians leaving the organization, which of course resulted in organizational savings. That perspective may be particularly useful thinking about the number of nursing vacancies in the UK, which are likely to be replicated around the world. So savings by fewer organizational costs, increased retention could have an impact in existing nursing vacancies worldwide. Those calculations seem fairly straightforward, but there may be much more difficulty thinking about how to apportion an economic value to, for example, the support provided by clinical academics to peers and colleagues and the wider profession. And in one of the papers here, you can see how that support is highly rewarding for the mentors, the clinical academics providing the support. And in here, you can see how happy they are helping someone to be a better clinician and a better researcher. And it's important to remember that clinical academics are meant to be mentors and encourage future clinical leaders and provide pastoral support. So how can we include the value and the impact of such activities within any economic calculation? And that just focuses on the profession and other professions, but there may be even more difficulty thinking about the apportioning of an economic impact and value to societal activities. So in this case, you've got an example here of the impact that research active workforce could have reducing health inequalities, so leading to increased financial gains, improvement to health and well-being. How can we allocate an economic value to such activities so then we can include these values into the economic calculation? And more interestingly, perhaps, the experience from McManus et al., where they identified how general practices which participated in research were larger, but also they were located in more deprived areas, leading to, again, substantial financial gains and improvements in health and well-being. It may be, therefore, that we need to apply a much wider lens to any economic impact and return on investment calculation, using tools which are validated, thinking about the working environment, perhaps using 360-degree tools, and considering not just the impact to the individual, patient and carers and the organization, but also national and international impacts and impact on society and societies, thinking from looking at economic impact from a planetary perspective. It may also be really useful to rethink the classic clinical academic concept, so not just those engaging in increased research and clinical practice, but also those engaging quality improvement and research practice, which may serve to improve the value for money of these roles. So to sum up, I've presented some of the limited evidence related to economic return on investment of the clinical academic role. I've suggested that the lack of economic evaluation may hinder the support for an increased number of clinical academic posts. And finally, that we need to really negotiate some of the caveats of expected outputs by clinical academics and consider the wider benefits of the role. Thank you ever so much for your time and attention.